anytime you want to. So, so acute kidney injury, the definitions, it's by definition a reversible decrease in kidney function. If it's not reversible, then it's chronic. So the fact that we call it acute means we think it can get better. It's generally defined by a more than 20% rise in the creatinine from baseline. There's a ton of different definitions of AKI, but the way I look at it, more than a 20% rise in the creatinine from baseline. If the urine output's below 400 milliliters for 24 hours, that's oliguria. And deciding whether someone's oliguric or non-oliguric is important in terms of deciding what the probable cause is and then what the way to actually address it is. The creatinine usually rises less than 72 hours from the onset of the injury, whatever that is. Die, shock, whatever it might be. Within 72 hours is when it usually starts showing up. BUN is, that's a test that we don't use a whole lot. It's there. It's limited efficacy because it can go up from steroids, from GI bleeding, from diuresis. Kidney injury doesn't necessarily get reflected by that. So it's just a limited use. And of course, as we know, complications of acute kidney injury, electrolyte abnormalities, volume overload, diuretic resistance, and uremia. Those are the major complications. Etiologies of acute kidney injury in the ICU, number one is usually drugs. Number two, hypotension, shock, and ischemia. Number three, IV contrast. We see it a lot from CTAs for PE workup and vascular studies. Once again, onset is usually 24 to 48 hours after the insult. Usually ATN is non-oliguric. So if their creatinine's rising and they're making urine, it's usually ATN. Okay. The course of ATN, so why does ATN happen? Well, as you guys know, the nephron is the glomerulus, which is the filter where the blood is filtered into the ultrafiltrate, which is what's pulled out of the blood by the filter. And then that ultrafiltrate travels through a series of tubules, proximal convoluted tubule, loop of Henle, distal convoluted tubule, collecting duct. And as it moves through these tubules, the urine is made. That's where the processing occurs. When you have ATN, the glomerulus is fine. The filter isn't damaged. It's the tubular cells. And the tubules are lined by tubular epithelial cells, like skin cells almost. Those cells actually are damaged, they die, they slough off of the tubules, and they clump inside those tubules. And so the fact that the tubules are full of sloughed off epithelial cells is why the kidneys stop working. So those have to be flushed out, and that's why the time course is. If those cells are damaged, it takes a certain amount of time for them to actually die, necrose, slough off, and then block off. And then as those are flushed out, new cells grow. As we know, skin cells come back. I mean, and that's the kind of cells we're talking about. So usually, if it's an uncomplicated ATN, it's a single injury type of deal. Now, I'm not talking about ongoing injury. I'm talking about if someone gets a slug of contrast, that's a single, sort of isolated injury. It takes about 3 to 5 days for the creatinine to go up and plateau. If there's no ongoing injury, 5 to 7 days for it to trend down and resolve. But dense ATN is a different story. You'll see me use that term, dense ATN. That means there's generally some ongoing injury. COVID, we saw that a lot. People would have ATN for weeks and months. Rhabdo will cause that. Folks who've got ARDS, they'll have that. So in these cases, they may have their labs may stay up for 6 months. I've seen that at times. Yeah. A lot of times we'll diurese them through this because they can still make urine, but because they're getting drips and they're needing nutrition and stuff, they'll get into volume problems, but we can diurese them through that. Sometimes diuresis actually helps because it sort of flushes those cells out. Okay, probably the second most common cause of AKI in the ICU that I see is cardiorenal syndrome. Cardiorenal syndrome is it's a specific type of kidney injury in a setting of cardiac problems. It's not just typical pre-renal state. It's where actually the CVP has gone up due to valve problems, decreased ejection fraction, arrhythmias, whatever. CVP goes up, that causes renal venous congestion. So it's not it's not a problem with the kidney filters. It's that the renal veins have become congested, and that causes sluggish renal plasma flow, that limits the GFR, and the creatinine goes up. So the most predictive physical exam sign of cardiorenal syndrome is JVD. If they've got JVD, good chance they have a component of cardiorenal syndrome. We can see it in systolic CHF, diastolic CHF combined. The treatment is diuresis, so it's pathognomonic. If they're in CHF and creatinine's up and you diurese them, the creatinine comes down, that's called hemoconcentration. That's the term we use. When you're diuresing someone for cardiorenal syndrome, it's hemoconcentration. You're concentrating their blood, decreasing their renal venous congestion. And so of course, creatinine comes down. That distinguishes it, and we'll talk more about this later, from just a typical pre-renal cardiac state, in which if you diurese them, creatinine goes up. Okay. And then pre-renal azotemia, you guys know all this. This is not super complicated stuff. But pre-renal, number one cause is volume depletion, nausea, vomiting, diuresis, extracellular fluids, post-op insensible losses, tubes, encephalopathies, all these kind of things. The treatment obviously is isotonic IV fluids. Isotonic because it gives volume, not free water, it gives volume. Normal saline or lactate derivatives are the two types that I use. And then pre-renal can come because of systolic CHF, valvular heart problems, specifically aortic stenosis. The treatment there is to optimize the cardiac output, afterload reduction, inotropes, and structural heart interventions. Okay? Anything that improves the cardiac performance will help the kidneys, because the kidneys depend on their prime from the heart. Of course, diuresis itself will cause pre-renal azotemia, and the prescription there obviously hold the diuretics or at least decrease them. That's obvious. Cirrhosis is a complicated type of pre-renal azotemia, and a lot of physicians, frankly, anytime someone has cirrhosis and they're swollen, the creatinine's up, they'll call it hepatorenal syndrome. That's not true. Most cirrhotic anosarchic pre-renal folks are just pre-renal. And so when you have true hepatorenal syndrome, the difference is it's a severe pre-renal state that doesn't respond to giving IV fluids. If someone's pre-renal and give them IV fluids, they'll get better. If it's hepatorenal syndrome, what's happened is the liver is where our bodies get rid of all the endogenous vasodilator substances that we make. We're making endorphins all the time, vasodilators, all these things. Sorry. And when the liver isn't filtering those things out, they accumulate. We get splanchnic vasodilation. The arteries in our gut just dilate out. We eventually get anasarca. We eventually get ascites. And so the treatment for true hepatorenal syndrome, which is a severe pre-renal state, but it's not just pre-renal azotemia. It's its own animal. And the treatment is the hepatorenal protocol, which is IV albumin, octreotide, and either pressors or midodrine. Okay, so you guys, usually if I come in, I'm going to give them a trial of IV fluids. If they perk up, then fine. If they don't perk up, then hepatorenal syndrome is possible. And the two typical signs you see is they're essentially anuric. They are not hardly making any urine at all. And their urine sodium is unmeasurably low. So we'll always check that. If it's unmeasurably low, not making any urine, that's the hepatorenal syndrome. Okay. So another thing we see a lot of times in the ICU is acute interstitial nephritis. This is a drug reaction. The mechanism is that it's sort of like an allergic reaction in the kidneys to drugs, but really what happens at the cellular level is it's an immune-mediated response where your immune system attacks the kidneys in response to a certain medication. So typical drugs, nonsteroidals, proton pump inhibitors, sulfa drugs, including diuretics, because Lasix, Bumex, those are sulfa drugs. Typical antibiotics, penicillin, vanc, quinolones, cephalosporins, and of course sulfa antibiotics. And the treatment, obviously, hold the offending drug. And so as the doctor, we need to be thinking, what are they on that could potentially be causing this? And if we hold it and they don't get better, then the steroid course usually calms that down. Usually in 4 to 6 weeks, creatinine's coming down. They're out of the ICU by then. You guys don't see that. But the things we look for is sort of sterile pyuria, white cells in the urine, but no other evidence of any kind of an infection. I'm sorry, I'm just okay. Go. And then post-renal, this is This is anatomic kidney failure, bladder dysfunction, neurogenic bladder anesthesia, bladder outlet obstructions from those various reasons. Then as we move up the urinary tract, ureteral obstruction, stones, masses, stents being obstructed, renal pelvis obstructions from stones and masses. Radiology findings, of course, bladder distension on bladder scans, hydronephrosis on sonograms. Pro tip, and this is not as big of a deal as it used to be, but I used to get calls all the time. Got the Foley in and not making any urine, and I would always say flush it, and 50% of the time that was the problem. Well, you guys are so comfortable with using bladder scans now, which I don't know why we weren't always doing this, but we bladder scan these folks all the time now, so we don't see that quite as much, but it used to be a reason I got called in the middle of the night a lot. So, okay. So let's go through some specific ICU settings. So acute kidney injury and sepsis is probably the number one reason we get called. It's either ATN from shock, pre-renal azotemia from systemic vasodilation, or it's post-infectious nephritis. That's the three things we see. So if it's antibiotic toxicity, that's either going to be, and so now I'm going to go back and use the terminology that we've been using. That's going to either reflect ATN or acute interstitial nephritis. If it's ATN, they're going to be non-oliguric, no creatinine response to giving IV fluids. If for pre-renal, they're oliguric, and the creatinine does respond. So that's the way I go through it in my mind. Post-infectious, we see a lot of staph nephritis. We see a lot of endocarditis-related nephritis. These guys have low complement levels. They're usually still making urine, and the treatment's antibiotics because the only treatment of post-infectious nephritis is to treat the underlying infection. Well, thanks for showing up, guys.
Yeah, thanks for having us.
You've already missed all my jokes about Hendon. I've given all the Hendon jokes.
The best nephrologist
Well, the best nephrologist in this room. That's no question. No, there's definitely no question about that. All right. Okay. Now, acute kidney injury and cardiac disease is probably the second most common reason we get called. So post-CT surgery, that's ischemic ATN. Post-coronary intervention, that's toxic ATN, also known as contrast-induced nephropathy. Post-AMI, usually ischemic. Acute CHF, that can either be pre-renal because of low cardiac output and the kidney's not getting perfused, or it can be true cardiorenal where the kidneys may be getting perfused, but there's enough CVP elevation, once again, to cause renal venous congestion. Treatment of those, of course, is hemoconcentration. Tachyarrhythmias usually causes pre-renal. Cardiogenic shock can either cause ATN, in which case the treatment is pressors and sometimes diuresis if they've got enough of a pressure. Cardiorenal syndrome, of course, diuresis. Pre-renal, you give inotropes because if you give diuretics in that case, they'll get worse. Okay. So acute kidney injury and respiratory failure, probably the third most reason we get called, and that's usually pneumonia or pulmonary edema. So pneumonia, they're on mechanical ventilation, they get pre-renal from insensible losses, decreased PO intake. Of course, the treatment there is giving IV fluids. If they have pneumonia and shock, just supportive and IV fluids, that's usually ATN. Pulmonary edema, the question is always, is it cardiogenic or non-cardiogenic? If it's cardiogenic, it's either cardiorenal syndrome, can have ATN there, treatment's usually diuresis. Non-cardiogenic, it's almost always ATN. That's ARDS, that's aspiration, that's post-transfusion. And the only one of those in which you diurese is if they've got ARDS, a lot of times we'll diurese them to try to dry the alveoli out a little bit, just to improve oxygen transfer. We did that a lot in COVID. Okay, so just to give you an idea of the way I think about it, when we get called and we come in and sort of everybody's got sort of a checklist in their mind of how they think about things. So when I first see the patient, the first thing I do is establish the baseline renal function, go back, are they a CKD patient? They have normal kidney function starting. That's the first question I ask myself. Second question I ask myself, what's the time course of the creatinine rise? Has it happened gradually over 2 weeks? Has it happened over 72 hours? That tells me something. Are they oliguric or non-oliguric? I look back, what's the probable inciting event? What's causing this? Then I'll look at the sort of the three diagnostic criteria that I have. What's their volume status? Do they have any significant metabolic abnormalities? And then what is acid base status? So that's the three biggies that I'll look at right off the bat. And then I look at my 3 things that I can do. What are the interventions that I have? IV fluids, diuresis, or if those fail, renal replacement therapy. So let's just go through those things and the way a nephrologist thinks about these things in terms of volume status. First off, obviously, a lot of this is kind of elementary for you guys, but the exam, JVD matters to me a lot. Peripheral edema, of course, mucous membranes, and radiology, pulmonary edema on the chest x-ray, body imaging, ascites, anasarca, effusions. And so, yeah, I like to think that nephrologists are the best at distinguishing the true volume status, because it's easy to see if somebody's swollen, but are they necessarily, what's the intravascular volume status? So that's sort of, I kind of think that's our regime a little bit there. The ins and outs are reliable in the ICU, they're not literally reliable anywhere else. Daily weights are never reliable anywhere within Covenant, so that's just, I wish they were. When they're trending in a certain direction, I pay attention to them. When they're up and down, they don't really help, but we always look at them, but they're not always helpful. Metabolic abnormalities, so the 2 that really matter the most in the ICU and that actually, kill or damage people, hyperkalemia and hyponatremia. So hyperkalemia, it's pretty straightforward. You guys deal with it, I know, almost every day, but just a brief overview of how I think about it. 5.2 to 6, exchange resins if they're taking oral, dietary restrictions, that usually fixes it in that range. 6.1 to 7, translocation therapy with D50 and insulin, IV calcium to protect the myocardium, exchange resin if they're taking PO, and then bicarb is usually indicated in that setting. And then 7.1 to 7.5, same treatment, and if they've got EKG changes, we dialyze them. Above 7.5, same thing, plus we dialyze them probably even if they're not showing any signs of arrhythmias. We just go ahead and get it down there, because getting it down from that level is going to take a long time. It's going to be a lot of work for you guys, a lot of calls, and we just say it's best to get it on down. Hyponatremia, a big black box. 95% of physicians don't know how to take care of it. But the bottom line is, it's all about the volume status. The sodium level in the blood does not reflect the sodium level in your body, hardly ever. It reflects how much water you have in your body. So think that sodium reflects your body water, then you know that the way to think about it is, what's the volume status? So if they're hypovolemic, and I already talked about the ways that we assess volume, exam and radiology, and if you come to the conclusion, sodium's low, they're hypovolemic, then you give IV fluids. You start with normal saline, isotonic IV fluids, and if the sodium comes up at the appropriate rate, 6 to 8 milliequivalents per 24 hours, and you're bringing it up at a rate that's safe for the brain, then great. But if the recovery stops, or if they don't recover, that's because our bodies can only dilute our urine to a certain extent. And you do get some free water with normal saline, so sometimes you give normal saline, it just doesn't come up. And that's because of the person's limited ability to dilute their urine, especially in acute kidney injury. So 3% saline is used. And that's usually for symptomatic hyponatremia, or if it's less than 120 and in that range. If they're euvolemic, that's usually SIADH. So you water restrict, you can give 3% saline if necessary, or you can give tolvaptan. Tolvaptan is a vasopressin antagonist. It blocks the aquaporin channels in the collecting duct of the kidneys, in the latter part of the nephron, the very farthest part of the tubules of the nephron. You've got these little water channels called aquaporins, which are what they sound like. They're porous to water. And so that part of the nephron, there's a lot of water in it's getting ready to be urine. It's not quite urine yet, it's the ultrafiltrate still. There's a lot of water in it. If those aquaporin channels are open, then that water's gonna rush back into the body and you're gonna retain water. If those are closed, you're gonna urinate that out. Tolvaptan closes those channels, makes you dump water. Okay?
So it's a vasopressin antagonist?
Mm-hmm.
Okay. I have a question after you.
Yeah. Go ahead.
I see, I think that was that you learned in nursing school that like your sodium's not supposed to change more than like 2 points in a couple, I don't know exactly the time range. But I feel like a lot of times you do see labs where where they change more than that. And I'm like, I feel like this needs to be addressed, like, you know, and then you think, is the lab still diluted, you know,
Yeah.
what changed,
Well,
like how much time between,
You have to ask yourself, number one, do you believe the lab?
yeah,
Remember, that's the first thing. Second thing is where did it start? If it started above 120 and it's corrected quickly, probably okay? The settings where that fast of a correction from low 120s to almost normal within a day is bad, is alcoholics and typically elderly women. They just don't tolerate those. Those are the two times. If it's below 120, you gotta bring it up at no more than about 8 per 24 hours. And if it does come up faster than that, you gotta relower it. The literature is very clear. If you relower it within 24 hours of the initial too rapid rise, you can prevent centropontine myelinolysis in almost every case. So, it's not good. We see it, we don't like it, we bring it back down. And so DDADP is my friend in that. I give them a lot of that.
Yeah.
And it'll bring it right back down.
so that's, you said over 120, you don't really worry about it as much.
I mean, I don't want to say I don't worry about it, but I mean, if they go from 122 to 129, I don't get too worried about it. If they go from 122 to 135, I probably don't like that. I'll bring it back down to the upper 120s, hold it there, and then come on up after that. Yeah. So I mean, I don't take it lightly.
Okay.
But those are the two populations that really get damaged a lot. Okay. And then hypervolemic are usually pretty clear. CHF, cirrhosis, you treat that with loop diuresis and water restriction. So that's what I think about hyponatremia, especially the acute kidney injury. But acid-base status, the two big ones that we see in the ICU, and I won't talk about respiratory types of acid-base abnormalities, but metabolic acidosis and metabolic alkalosis. So metabolic acidosis and AKI, it's either an anion gap or non-anion gap. That's the first question in my mind. What's the anion gap? If it's anion gap acidosis, it's usually lactic, keto, maybe due to acute kidney injury, or they may have an osmolar gap, which means they may have ingested some toxic alcohol. So if it's lactic acidosis, the treatment obviously hemodynamic support, IV fluids, and stop tissue death. Ketoacidosis, obviously DKA, starvation ketosis. The treatment's D5 and insulin. Acute kidney injury, this causes basically an anion gap acidosis because of phosphoric acids, organic acids, non-measurable acids. The treatment is IV fluids, bicarb. That's where you'll see a bicarb drip a lot, and dialysis if they need it. And so if someone comes in and they don't have a lactic acidosis or ketoacidosis, and they got kidney injury, but you think the gap is out of proportion to what you would expect for this degree of kidney injury, then you think about an osmolar gap, and you just calculate that real quick. You send off a serum osmolality, you calculate one, and if there's more than a gap of 10, you got to think about a toxic ingestion, like ethylene glycol. And we don't see that very much, but sometimes we'll dialyze them just in case while we're waiting on those labs to come back. Non-anion gap acidosis, we see that in acute kidney injury all the time. It's because, once again, a non-anion gap acidosis is usually caused by tubular dysfunction, and the tubules are what's damaged in ATN, so a lot of times we'll see tubular dysfunction with a non-anion gap acidosis. The CO2 is low, the anion gap is normal. We treat it with IV fluids, bicarbonate, loops, and sometimes dialysis. We'll see non-anion gap acidosis all the time because of GI losses, because when you have diarrhea, you lose a lot of bicarb and causes a non-anion gap acidosis. The treatment is bicarb. We'll see RTAs, once again, because of ATN. Once again, treatment, bicarb and loops. So, in terms of metabolic alkalosis, that probably doesn't ring a bell with you guys too much. You guys probably don't deal with that all that much. We see it because we're watching that every day, and so with the metabolic alkalosis, it's usually one of two things in the ICU. It's either because they're volume depleted, which is what's called a chloride responsive alkalosis. The way we check that is we see a low urine chloride, and so volume depletion or post hypercapnia. So volume depletion, obviously you replace IV volume, you do it with normal saline. because that gives volume and chloride, because it's a chloride responsive alkalosis. You decrease or stop diuretics. If those two things don't help, then you give acetazolamide, which is Diamox, and that makes the kidneys actually dump bicarb. And a handful of times in my career, I've had to dialyze somebody because of a non-responding metabolic alkalosis, because if the kidneys aren't working, they can't get rid of bicarb, and the bicarb just floats around your body forever, you gotta dialyze it off. Post-hypercapnia is another thing. When folks are hypercapnic, if they're hypercapnic for very long, the kidneys will respond and compensate and hold a bunch of bicarb, and so that's their appropriate compensation mechanism. And then if they have acute kidney injury, then they're not able to start dumping it again. So a lot of times they will need IV normal saline, they'll need a acetazolamide trial, and if they don't respond, then dialysis is necessary. So that's the two times we see that. So then I talked about our three interventions, our IV fluids, diuretics, and dialysis. So in terms of IV fluids, it's all about the tonicity of the IV fluids. So either isotonic, hypotonic, or hypertonic. That's the three major categories. So isotonic. Now there's other types of IV fluids. These are the three that I use. This is the way I think about it. In terms of isotonic IV fluids, I use normal saline if it's prerenal azotemia, volume depletion, sepsis. I use lactated ringers if they've got a mild anion gap acidosis, if they've got a non-anion gap acidosis, and if they're currently NPO, but they have preserved hepatic function. Why does the hepatic function matter? Because lactate is your buffer, but lactate is an acid, but the liver converts lactate to bicarbonate. So you got to have your liver working. Otherwise, you give lactated ringers, you're going to get a lactic acidosis. So, and then an isotonic sodium bicarb drip. So 1 amp of bicarb is 50 milliequivalents of sodium, and so to make it isotonic, you have to give 3 amps because your body its tonicity is 140 milliequivalents. So 3 amps is 150 milliequivalents of sodium. So giving 3 amps of bicarb per liter of water is the same as giving normal saline in terms of your kidneys. Does that make sense? Okay?
Yeah, never thought about it that way.
Yeah.
Me neither.
So that's why, you'll see somebody being given, 2 amps of bicarb per liter of D5W. Well, you're giving them 2/3 normal saline. You're not giving them, you're giving them a bunch of free water. And if they're hyponatremic, you don't want to do that because it's going to make it worse. A lot of times what you'll see stat care give is 1 amp of bicarb with half normal saline. Well, they're given 3/4 normal saline then. They're not, so I never understand why to do that. Why not go ahead and give them the equivalent? Because you guys understand, when you give normal saline, when you give isotonic IV fluids, you're giving pure volume. That is volume. Because, why is that? Because the saline stays in your bloodstream. It's intravascular volume. When you give free water, hypotonic IV fluids, you're giving only partial volume, and then you're giving some free water. Half normal saline it's like giving normal saline plus D5W, right? And so but the water isn't volume. You can see it in a glass, it looks like volume, but in your body, it's not volume. It leaks out into all your body tissues, into your muscles, into your eyeballs, into your CSF. It's not volume, it's just free water. So hypotonic IV fluids, when do you use those? Well, half normal saline, I'll give those when somebody's got some volume depletion, because we're giving them some saline, but they've got mild hypernatremia, they're NPO, they have NG suction, they need some water and some volume. Quarter normal saline, I'll sometimes give that to the consternation of the pharmacy because they have to mix it up, but it's got its place, because then this is for folks who've got hypernatremia and also have hyperglycemia. So I don't want to give them D5W, but I want to give them a bunch of free water, and maybe they can tolerate a little bit of volume. So quarter normal saline is mostly free water, but a little bit of volume in it. D5W obviously is the hallmark of hypernatremia correction. If they're relatively normoglycemic, that's okay. If they don't need any volume given, that's okay. It just gives free water only. And then if you want to give some buffer and you want to give some free water, then that's when you can do sodium bicarb 1 or 2 amps per liter. And you're treating an anion gap acidosis, you're treating hypernatremia as well. So it's got its role. That's a hypotonic bicarbonate drip. And then hypertonic is really only used for severe symptomatic hyponatremia. So,
Do you ever take into account that, our drips used to be mixed in saline, and now they're mixed in D5W?
which,
Like, Levo,
yeah.
things like that?
Yeah,
Did you,
no.
that change happened, I don't remember when that change happened.
Yeah.
Like, it was like, maybe right after the pandemic, but like, does that ever make it, do you ever see that make a difference?
Oh, yeah, when folks are on pressors and they're symptomatically hyponatremic, you gotta take that into account because you want them to be water restricted. And so I've actually talked to the pharmacy before and I've had them mix some things in saline for me. There's some things they can't, I don't think amnio can be mixed in saline. So there's a few things. Yeah, there's a few things that we can't change, but they can change some of those things. Most of them aren't compatible.
If you couldn't change it, what would you do then? What would you try to do solution-wise?
Well, if you couldn't change it and they're on drips and they have to be continuing to get water like that, then that will make me get more aggressive with my hyponatremia correction, okay? So maybe use a higher dose of tolvaptan. Maybe have to use hypertonic saline instead of normal saline. So you just have to be aware of it and kind of sort of adjust to it. Okay, so how do I think about diuretics? So obviously when they're pre-renal, we hold and avoid diuretics, that's pretty clear. When they've got ATN, so if they're oliguric, if it's oliguric ATN, which we don't see all the time, we see that in these dense ATN folks. Then we want to convert them to non-oliguric because non-oliguric ATN is much more easily managed than oliguric ATN. So we use loop agents, Lasix, Bumex. They'll usually respond to that if they've got oliguric ATN. Non-oliguric ATN will still diurese them sometimes because in the ICU they're getting nutrition, they're getting drips. Then we're in the process of maintaining urine output and preventing volume overload. And then there's the question of continuous diuretic drips versus bolus dosing. Why do we use, which do we use? And if you look at the literature, overall bolus dosing of loop diuretics and drip dosing is, in the big picture, is pretty equivalent in terms of response, but it's pretty clear that there are cases where drips are best used. So I will start with bolus dosing and then I'll convert to a drip if they have a sluggish response to the bolus doses. There's some evidence that drips can achieve better serum levels, and it's important to get these serum levels because just think about the fact that the functional part of the kidney is the cortex. It's the outer part of the kidney. That's the part of the kidney that's going to get ischemic when blood volumes are low, when they're vasodilated, when they're just not perfusing well. The outer rim of the kidneys are the places that aren't going to get the best blood flow because it's the farthest from the blood source, which comes into the highland of the kidney. So if you want to get the best serum levels out into the outer reaches of the kidneys, a drip will help with that sometimes. And then the other thing in my mind is that it's easier to dose thiazides when you have an ongoing loop drip. So a lot of times you're giving them a loop, they're not responding, they're making 1 liter of urine, but you want them to make 3 liters because they're volume overload or whatever. And so you might say, okay, I'm going to add some metolazone or I'm going to add some diuretic. Why do we do that? Loop, remember the nephron, the glomerulus, proximal convoluted tubule, loop of Henle, distal convoluted tubule, and collecting them. The loops work in the loop of Henle. Okay, that's where they work, and they make your body dump sodium into the ultrafiltrate, the nascent urine, and then but as that ultrafiltrate travels further out into the distal convoluted tubule, your body wants to reabsorb some of that. But the thiazides work in the distal convoluted tubule, the DCT. So you give the thiazide out there to prevent that reabsorption, so you amplify the effect of the loop. Okay, so. But if you want to do that, you need to, if you're going to use a thiazide with bolus dose diuretics, you need to give it 30 minutes beforehand. Well, that can be sort of a problem sometimes. And so then you got to make sure you're dosing appropriately, and the pharmacist knows, and the nurse is aware, this is what I'm doing. But if they're on a drip, you can literally give it any time. You can go ahead and hit them, they're just on a drip, you give them a dose of diureal, works beautifully. So that's why I'll use it sometimes. Continuing with diuretics, so in cardiorenal syndrome, obviously loops, plus or minus thiazides for hemoconcentration. We talked about that term, hemoconcentration.
But that's pretty obvious. Spironolactone, why do we use spironolactone? Well, obviously, it's an MRA, mineralocorticoid receptor antagonist. It offsets the hypokalemic effects of loops and thiazides. Remember, aldosterone is our hormone that our adrenal glands make that tells our kidneys to dump potassium. And then you're given loops, and the loops make you want to dump potassium as well. You give spironolactone, it blocks that aldosterone effect, and your body will hold on to potassium. That's why it's a potassium-sparing diuretic. So it's a nice offset when folks are getting loops and thiazides. Also, spironolactone is found to decrease cardiac fibrosis, it improves survival in CHF with reduced ejection fraction. So it's something, it's really goal-directed therapy now. So that's another diuretic that we use a lot in cardiorenal syndrome. In cirrhosis and AKI, you'll see those folks come in on spironolactone. Spironolactone is the diuretic of choice in cirrhosis. Why is that? Well, once again, because aldosterone effect. Aldosterone is secreted by our adrenal glands in response to decreased intravascular volume. It's basically an evolutionary response to getting volume depleted. But in cirrhosis, what happens? You don't have good intravascular volume because your third spacing, ascites, anasarca, and so the adrenal glands think we can make a lot of, a ton of aldosterone. But that makes you just retain more fluid and get more fluid. So spironolactone blocks the hyperaldosterone state, and it works very well in cirrhosis. But sometimes spironolactone is not enough in bad cirrhosis, so sometimes we'll add loops, and a lot of times we have to use both of those to control ascites. The main thing to think about with diuretics and cirrhosis is that diuretics can precipitate hepatorenal syndrome. So somebody might be, that's why, I take it very, I take it very seriously. Are they pre-renal or are they hepatorenal? If they're pre-renal, you can push them over into hepatorenal by giving diuretics. And so you have to be real careful with those in that state. The two times when cirrhotics can get tipped over into hepatorenal syndrome is if they've got SBP or if they're intravascularly volume depleted at the time of the diuretic. So if you give diuretics to cirrhotics and the creatinine goes up more than 20%, you gotta stop it, or you'll tip them over and then the horses are out of the barn. So, okay, dialysis. So you guys know so much. This indications for dialysis: metabolic, volume, and uremia. So metabolic, hyperkalemia, we talked about that. Potassium above 7, EKG changes. Sometimes we'll do it earlier, but those are the most common settings. Metabolic acidosis, that's not amenable to bicarb therapy. Either they're not responding to the bicarb therapy, or they're responding to it but they're going into volume overload. Because of the volume of it, dialysis becomes necessary there. In volume overload, that's refractory to diuretics, or maybe they're diuresing, but they're still not diuresing enough to meet the IV needs that they're getting. Sometimes you have to dialyze them in that setting. We dialyze folks because of uremia. Uremia, old Victorian era term for symptomatic kidney failure. It manifests in the ICU with encephalopathy and GI bleeding because of uremic platelet dysfunction. So we'll dialyze them because of those things. And then after you decide that someone needs dialysis, then you think, okay, what's the dialysis modality? What do we do? So standard acute hemodialysis is our workhorse. It's what we usually do. If they're stable and they can tolerate it, we'll talk in just a minute about, in my mind, what the reasons to use either one are. But if they're not a standard acute hemodialysis candidate, then CRRT is the next step. We do have hybrid modalities. We've used them a few times. We have SLED, which is slow, low efficiency dialysis, and we've got SCUF, which is slow continuous ultrafiltration. Basically, bottom line is those are just long dialysis runs. Those are where you guys aren't doing it. The acute nurses are coming over, standing there with the machine, use the baby K machines, the regular machines, and with SLED, we just dialyze them on a low blood flow rate with the typical filter and do it for 6, 8, 10 hours, okay? SCUF is just the same thing, except we're not dialyzing them, we're just ultrafiltrating them for 6, 8, or 10 hours. But that is just so hard to get those dialysis nurses over to do it. We just don't do that much anymore. But there are possibilities. We can do those if we don't have a CDH machine available, or for some other reason. Those are possibilities. And in peritoneal dialysis, there's a lot of excitement a few years ago about using it in the ICU. It's just rarely used acutely. They get hyperglycemic, they have to have the catheter put in, it's a problem. So I put that in there because it's in the literature, but we don't do it here. I think it's JV, not strong. Okay, standard hemodialysis, patient selection. So number one, the question is, will dialysis bridge this patient to recovery or survival? Yes, it will. Okay, let's think about doing it. Are they hemodynamically stable? This is for standard dialysis. I'd like to see a MAP stable above 65, not 60 to 70 to 62 to 67. I like to see them stable above 65. One pressure or less and weaning. That's kind of in my mind. But the big thing is they've got to be able to tolerate a blood flow rate of 300 to 500 milliliters per minute for 2 to 4 hours. That's a significant stress on someone when they're sick. So 3 to 5, that's running your blood 3 to 500 milliliters per minute through this filter for 2 to 4 hours. That's not negligible. So that's what you got to be able to tolerate that kind of dialysis. Of course, vascular access for acute non-tunnel dialysis catheter, IJ's far preferable to femoral. Subclavian veins used to be used, it's not used anymore because of the high rate of subclavian vein stenosis. So we almost always get IJs here. And then CRT. So patient selection, once again, you gotta make sure we can do it, but will the patient benefit from it? Are we doing it for them or to them? So we gotta make sure that it will bridge them to recovery or survival. A lot of times these folks are needing IV nutrition, huge IV drip needs. Maybe they'll tolerate standard dialysis, but the 20 hours between standard dialysis treatments, they're not getting any sort of dialysis, and they're getting TPN, they're getting IV fluids, and they're going to get into trouble in between. So CRT is appropriate there. These folks are usually hemodynamically unstable. Kind of in my mind, the cutoff of 65 is sort of the map that I think about. These folks are usually on more than one pressure, or they're not being weanable. And these are folks who fundamentally will not tolerate a blood flow of 300 to 500 mils per minute. So CRT is perfect. So the modalities that we typically use here, CVVHD, which is continuous veno-venous hemodialysis. Though that technically you're not using replacement fluids there, okay? That is CVVH without replacement fluids. CVVHDF, which is what I always do, is continuous veno-venous hemodiafiltration. That's where you're using replacement fluids, because with the replacement fluids, it enables you to increase the ultrafiltration. And when you increase ultrafiltration, you also increase subsolute removal, because with ultrafiltration, you're taking off fluid. And that fluid pulls waste products. It's called solute drag. It drags excess weight, so you get better clearance when you're taking off volume 2. So that's what I tend to use. So the orders, the Prisma filter was what we historically used here. QB is the blood flow rate. I'm getting pretty nerdy here with the terms, but blood flow rate, remember with standard dialysis, 300 to 500 mils per minute. With CVVHD, F, I almost call it CVVH, frankly, but it's 200 mils per minute, so it's about half of what you would, so it's about half as much of a stress on the heart. But the reason you can use the slower blood flow rate is because solute clearance, which means dialysis efficiency, how much waste products you're clearing, it doesn't depend on the blood flow. With standard dialysis, how much dialysis you give the person depends on the blood flow. That's why it's got to be 300 to 500 mils per minute. With CVVH, it's dependent on dialysate flow. It's a completely different physiology. So the dialysate flow, the QD, is 2,000 mils per hour, which equals out to 30 to 35 mils per minute. So the clearance depends on the dialysate flow. And so in standard dialysis, the dialysate flow is fast, 500 to 800 mils per minute, but the clearance was dependent on faster blood flow, okay? You guys following this?
Mm-hmm.
But in CRT, the principles are this. The clearance depends on slow, saturated dialysate flow. In the filter, the blood's flowing one direction. This dialysate is flowing the opposite direction, bathing those little fibrils, okay? And it's countercurrent flow. And what you want is that dialysate to flow so slowly across the blood that's going the opposite direction, that it saturates, that each milliliter of dialysate is completely saturated with solute, okay? So you want the blood flow rate's gotta be at least twice the dialysate flow rate. And so technically the way we do it is blood flow's 200, dialysate's 35, you are totally saturating that dialysate. That's why it's pretty efficient. It's not fast. You don't want to do it for hyperkalemia, because it's going to take hours to get the potassium down. Standard will get it down like that, but the CRT doesn't do that. So, but you'll always see me come in and check the machine. What I want to check is, what are we delivering? Are we delivering adequate dialysis? And generally, the goal is to deliver 30 mils per minute of solute clearance. And so if you got a dialysate flow of 30 to 35 up there, you're generally delivering at least 30 mils per minute of clearance. So that's what I look for. Does that make sense? Does that all make sense?
If you have a patient that can't go on standard dialysis and you need to do CRRT for hyperkalemia, what would be a standard dialysate flow?
Probably you wouldn't change the dialysate flow. You would, in that case, you would change the blood flow a little bit, because you would get some incremental improvements. Because the dialysate flow, you want it to go slow. Okay, you want slow and saturated. Blood flow, the only reason we run it that low is because they're usually unstable. You could bump it up to 400, the same as in standard dialysis, but usually most of these folks won't tolerate it. So if I see somebody that for whatever reason can't have standard dialysis, they need CRRT with case 7, instead of a blood flow of 200, I'll usually say 300. And it'll get down a little quicker, but not as good as standard dialysis too.
And is that also where Laura had said, like, you would use like a 2K bag?
2K, but yeah, I mean, you can either use a 2 or a 4K. So I'm gonna talk about those here in just a second. So let's talk about the fluids. So I don't mean to ignore you, but I'm gonna come back. So with the fluids, you'll generally see me use a calcium drip. I don't know if my cohorts all do that, but generally if you don't give a calcium drip, you're gonna be given a lot of calcium with the serial labs. I think it's a waste of y'all's time. I just don't think, so I usually run a calcium drip. It's just you're just giving more volume, which means you're getting more, you're taking off more UF. If everything else is equal, you're getting more solute drag. It just helps, and it prevents having to give a ton of calcium replacement. But you don't have to do that. That's sort of my little, everybody's got their style. That's kind of my style. I just do that. And so with the dialysate, once again, it runs counter current to the blood. It removes solutes by diffusion. Remember, if the person's potassium is 6 and the dialysate potassium is 2, then you got a gradient of 4. The potassium is going to move from the blood to the dialysate. And so you decide what you're going to use based on the potassium and calcium concentrations. Your number 1 monovalent cation, your number 1 divalent cation, potassium and calcium. And so you'll see I usually use 2/3.5. If the K is high, it's a 2K, and then the calcium of 3.5 tends to cause less hypocalcemia. Acute kidney injury patients are generally hypocalcemic. We used to use 2/0, but they need a ton of calcium replacement. I usually have to bump up my calcium drip. We have to give a lot more. We use that when we used to not have the 2/3.5, but I haven't used a 2/0 in a long time now. Then we have the 4/2.5 if their potassium is normal, or after they've been on CVVH for a day or two, potassium's come down, you just want to keep them there, and you might use a 4/2.5. Does that make sense? Okay, pre-filter fluids and replacement fluids. What's the reason for the pre-filter fluids? Pre-filter fluids are to dilute the blood and the solutes in the filter to limit clotting and prolong filter life. One of the reasons that we don't give good dialysis sometimes to the CVVH folks is because we're changing the filter so often that we've got a lot of downtime. The downtime means you're not getting any dialysis. And the whole idea of CVVHD is the C is for continuous. You want continuous clearance. Our bodies expect continuous clearance because our kidneys are supposed to be working all the time. So the more continuous your dialysis modality, the better it is. That's why PD and CRRT are the best types of dialysis. They mimic our own body's continuous clearance. So when you have a lot of clotting and loss of filter, you're losing dialysis efficacy. So pre-filter fluids are to dilute the blood, dilute the solutes, improve filter life. Now, they decrease dialysis efficiency a little bit, because think about it, when you're flooding their blood with a bunch of fluids before the blood hits the filter, then you're diluting the potassium, the urea, the creatinine, all those things are diluted. They don't move across the filter as well then, because their concentrations look lower. So we've made the decision, which is better, a little bit less efficient clearance minute to minute to minute, or having to take the whole thing down and change the filter every 12 hours. I'd rather have better filter life. So, and I use the same pre-filter fluids. You know, some of my colleagues will, you know, they'll only use one fluid for one thing, one filter for another, think that's sexy. It ain't sexy.
That's JV.
Listen, we're nephrologists. There's nothing sexy about nephrology. It's nephrology. I tell him that all the time. It's not cool. It's not sexy. It's just nephrology. So I use the same dialysate. I try to use the same fluids for everything as much as I can. It just makes it consistent. And the replacement fluids are post-filter. So these are used to restore plasma volume, restore electrolytes, and the buffer base, because you're going to lose some buffer in the filter. So you get the replacement fluids to help restore your buffer base. But the main thing is that, as I told you before, the replacement fluids enable you to increase your rates of ultrafiltration. That's what the definition of CVVHDF is. It's diet filtration. You get some better solute clearance. It's easier to remove fluids. And once again, I use the same fluids as the dialysate, unless they're very acidotic, and in which case I'll use a bicarbonate, isotonic bicarbonate. Does that make sense, guys?
Mhm.
Okay, CRRT continued. So CVVHDF volume management, so UF goal. So we always order a net hourly UF. So sometimes there's some confusion between the nephrologist and the nurse about that. I don't know, but I mean, I think the way to think about it is you take your total hourly in, what's the patient getting in, their lever fed, their TPN, everything they're getting. You kind of have an idea, maybe they're getting 200 in an hour, and you need to take out what they're putting out, estimate their urine, their stool, and what their insensible losses if you want to, and the difference in that is their net, okay? And then you set your UF rate based on that net. So then we give you a balance. We say we want them to be even. So then that means we don't want any net fluid removed, right? So you set that based on what their net is, right? If we want them to be positive 25 an hour, then you're gonna remove less ultrafiltration per hour than what their net is. Say their net is that overall they're positive 75 an hour. We want them to be positive 25. You set the UF rate to positive 50 and use your positive 25. Vice versa for the negative balance.
So based off of like your intake and output, because I know there's multiple places where we can see the intake and output. So whenever you all look at the chart and you are looking at their UF balance and their intake and output, where do you look specifically? Because sometimes I feel like there's a big discretion between different providers of where they look for intake and output.
Well, we've got a tab on our Cerner pages, that's got their total in, their total out, and the total in is broken down into the various things, the total out's broken down, and so, and then one of those line items, if it's a spreadsheet, one of those line items is CRRT or CVVHD. You guys put it in however it's going to be labeled. That's where I look every day. And so, it's what I'll just kind of come in and I'll sort of eyeball it, and if I know that I've got them set at negative 50 per hour, right, then I should come in the next day and their total balance should be negative 1,200 milliliters. That's 50 an hour, right? And if they're not, if they're even, then there's some problem, right? Either there's been something clinical happen, or else I haven't explained what I want correctly. So does that kind of give you an idea right there of the way I think about the ins and outs and the balance and the net hourly UF? And then, because some people will say, well, I'll say, well, hey, I set it to remove negative 50 an hour. And they'll say, we got it set at 50 an hour. And I'm like, Now, your total, you're taking off 50 an hour, but their net with everything else they're doing is positive 100, so they're positive. So you gotta take that into account before you set the UF rate.
Mhm.
And then a lot of times, I mean, I like to give titration parameters. I like to say titrate the UF to a CVP of 6 to 12, or to keep the map above 65, because to me, you guys are there with them every minute, and you guys need to have something to sort of titrate it to. That's the beauty of CRT, is that you can titrate it minute to minute, you can get it right where you want it. And if they get blood, boom, the next hour you adjust for that, right? So, CRT anticoagulation used to be a huge topic, but we don't tend to use anticoagulation most of the time. I think it's just because in the modern era, most everybody's on some kind of anticoagulation, it seems, for something or another. So most of the time we don't use any anticoagulation. Sometimes we'll use limited anticoagulation. We're having poor filter patency, and we don't, but there are bleeding risks, so we'll do some heparin, and we'll ask for a PTT of 45 to 60, something like that. Sometimes we'll need full anticoagulation, PTT 60 to 90. The agents that we use, mostly IV heparin, really around here only IV heparin. The two main types of CRT anticoagulation are regional citrate versus IV heparin. The IV heparin, you have more bleeding, but it's tons more practical, okay? You can either use the heparin syringe, which you guys would manage. You can do peripheral drip, which pharmacy monitors the PTTs and works with you guys on that. Our Gatraban, there's a literature about that. Pharmacy usually manages it, we rarely use it. Regional citrate is certainly less bleeding risk than heparin, but it's rarely used. And why is it rarely used? Because it requires a ton of work. It's very labor intensive. They're running calcium drips, they're running citrate drips. You have to monitor serial ionized calciums and serum calciums, and you have to calculate the ionized to serum calcium ratio. And based on what the ratio of ionized to serum calcium is, then you guys are adjusting the citrate drip up and down. And you get a lot of hypercalcemia, you get a lot of severe metabolic alkalosis. So it's labor intensive, it's lab intensive, it's pharmacy intensive, it's super nursing intensive. I don't think it's got much place. I mean, it's on our, I can do it.
No, sir.
But I don't do it. Okay, so then sort of wrapping it up then, I guess I've talked too long, I'm sorry guys.
You're doing perfect. Keep going.
But, so just troubleshooting in terms of arterial alarms, that's the blood going to the machine. Usually that's a port suction issue where the little ports on the catheter is sucking up to the wall of the vessel. Usually repositioning the catheter will fix that, not always, but that's generally what will happen. Venous alarms is usually fibrin sheathing or clotting. IR usually needs to change that catheter. Sometimes we can add heparin, but generally by the time we're getting those alarms, the catheter is sort of on its last legs in my mind. Filter patency, the goal is to get it well above 24 hours per filter. I like to get 72 hours, but because we don't like to use a lot of the heparin anticoagulation, if we can get 24 to 48 hours, I'm generally probably okay with that. Lower patency means less efficient dialysis due to more filter changes. And you can improve this without heparin by increasing those pre-filter fluids. So a lot of times I'll do that. And then the pet peeves of the nephrologist obviously is just not achieving the prescribed fluid removal. Coming in the morning and nothing's been taken off, or very little's been, or they're positive. And so that's usually due to hypotension, and the way to address that is adjust the pressors, maintain the map, control the arrhythmias. The arrhythmias are a big problem in that. And then also it's due to large volume intake. They got blood, they got this, they got that. And the way to do that is for the nurse just to be really on top of adjusting the hourly UF in the next hours after the bolus of volume. So that's it. You guys any questions? I mean, is that helpful at all?
Yes.
Good.
Great. Thank you,
Good.
Dr. Newman.
Yeah, sure, no, I'm good.